Today we have two great talks from Nicholas Bannholzer and Nina Wiedemann. The first one's going to be about the impact of non-pharmaceutical interventions on documented cases of COVID-19. This talk will last for about 15 minutes, and afterwards we'll have a Q&A session. Then there will be the second talk by Nina Wiedemann about automatic detection of COVID-19 from a new lung ultrasound imaging dataset. And we're not talking too much before and jumping straight in, so we can use the time for the talks in the Q&A session afterwards. The first one will be Nico. Just a quick introduction of Nico. He's currently doing his PhD at the Chair of Management Information Systems at ETH Zurich, and his background is mostly in economics and finance. And if you have questions afterwards for him, you can already type them in the chat right now during the presentation if you want to, and we will read them out afterwards. Or afterwards, you can also raise your hand, and we will have you ask the question in person. Nico, are you ready for the talk?
Yes.
Perfect, then I'm gonna give you the screen.
Yep. All right, can you see my slides? Can you hear me?
Yes, it's perfect.
All right, thank you very much for having this opportunity to talk here. First of all, I want to make an important disclaimer because I know this could be a polarizing topic. So to make sure you all get it, the content of the paper is the content of the paper and shared by all co-authors. But apart from that, all my opinions belong to me and only to me. Therefore, if you wish to write any rage emails afterwards, please address them to me and only to me. Apart from that, yeah, if you want more details, please read the medRxiv preprint that you see the link here. I won't go into methodological depth. Therefore, please refer to the paper. And also, if you wish to try out the model yourself or see the data, check out the GitHub repository. So to start with a little bit of background, what we were doing is trying to estimate the impact of the non-pharmaceutical interventions, so the policy measures that many governments were implementing to controlling the spread of the virus. These non-pharmaceutical interventions, of course, are not a free lunch. They come with costs, both economic and mental health costs. I mean, economic-wise, we all probably saw the stock market tumbling, the local restaurants and bars closing, and probably a lot of companies won't survive the corona crisis without a lot of support from the government. But also mental health costs are involved with people in a long lockdown. This is not sustainable for their psychology, and people with psychological disorders need help in this situation, as well as the elderly people not seeing their grandchildren. So with all this said, it's clear that the non-pharmaceutical interventions, especially the strong ones that were implemented, they are not sustainable. We can't hold them forever. And that is why our research question was to ask which non-pharmaceutical interventions, abbreviated NPIs, were the most effective in order to see, for example, if there's a second wave, or now with the talks about removing NPIs, which one could be prioritized and which one we should keep for a little bit longer. First of all, let me start with the data. My feeling is often that data science is a lot about methods, which is funny because it's called data science, so it should be a lot more about the data. And from my opinion, good data is imperative, and it's the most crucial aspect of our work as well. We spend a lot of time gathering the data, but I can't tell you I'm 100% sure it's correct. We had a lot of debates about many data points in our data set. So I give you a little bit overview of the process, how we collected the data. So first, we're gathering granular raw data on a country level for a few countries only. We started with Italy, and over time, we realized that there were very much country-specific differences. So the granularity was nice, but in order to model this kind of data, we realized we had to categorize the NPIs to make them comparable among countries. And we categorized them into 7 non-pharmaceutical interventions. These are school closures, border closures, event bans, gathering bans. In comparison to event bans are the ban of gatherings of small groups of people. For example, in Switzerland, it was only allowed that 5 people could meet in public. Then venue closures, which is the closure of bars and restaurants, as well as venues of recreational activities. the lockdown, which is that you can't go outside anymore unless to go shopping or to the pharmacy. And work ban, which is really a ban and not a recommendation as by many governments, but really the prohibition to go to work for non-essential business activity. So after we categorized our more granular data into these 7 NPIs, we tried to determine the dates. And this means that we set the first date once a measure was implemented. So for example, event bans is a really good example, because first many governments started to prohibit events of more than 5,000 people, then more than 1,000, then maybe more than 100. What we did was always choosing the first date. So in that case, the one with 5,000 people. So after we made this categorization and determination of the dates, we gathered the data for all the 20 countries we have in our data set. And thereby we had to deal with regional disparities. For example, in Germany or the United States, different regions were acting quite differently, and some regions more proactively because they had the more regional, stronger outbreak. So they needed to implement more drastic measures first. To deal with that and to aggregate the data in some sort of way, we decided that we set the date for a country with regional differences once 2/3 or more of these regions have implemented the corresponding non-pharmaceutical intervention. And finally, to double check our data, we consulted people, local residents or native speakers from the corresponding countries to check if they think the date is right, or if the measure is, for example, not implemented in their opinion. This, for example, was often the case with work ban, when we thought it was really a ban, but people said, no, it's rather a recommendation. So we checked with them, and also there was, for example, the difficulty with terminology. So different words were used for the same non-pharmaceutical intervention. And if you're an outsider and don't speak Portuguese, for example, you may miss on that if you're trying to get the data for Portugal. And all this data is then summarized into descriptive plots. And one of my favorites out of the paper is the heat map you see on the left, which can basically answer two questions. So if you go by row, you see for each country what measures they implemented and when. And there you can see if they, there you can see if some countries decide to not implement the measure at all and which one they were prioritizing. And by column, you can compare countries. So for example, if Spain reacted after more cases than Belgium, for example. We decided here to choose the metric of cumulative cases because we thought in the very early beginning of the pandemic, countries more looked at the absolute number of cases, not related to their total population. But of course, over time, it's less comparable. For example, with the United States, which implemented lockdown or work ban quite late, it seems that they were acting very, very late. But in that case, it would maybe make sense to compare this metric by dividing the cumulative number of cases with the total population count. We have this graph as well in the supplements, and for example, it would also be an opportunity to choose as a metric the days since the first case until NPIs were implemented. But nevertheless, the general concept of the heat map, I think, allows very nicely to compare countries and look within country differences. So this is about the data, and in my opinion, the data is absolutely imperative, because every mistake or every issue that you have in the data that you don't fix will cost you 10 times later in the modeling, and you need more complicated modeling. You have less robust results and stuff. So I was trying to slow things down there and telling our data collection team, take it slow. It's more important that the data is correct than that we are fast. But now let's come to the methods. We started simple here, in my opinion, as well. There are basically three important components. First of all is the outcome of interest, which here is the number of new cases for country R on day D. This is modeled by a negative binomial distribution. And here, let's focus on the mean parameter mu. And this parameter mu, the mean, has two components, which is the cumulative number of cases and the expected log incidence rate eta. First, the cumulative number of cases C for country R on the AD. This is basically the exposure in the negative biasing from the parameter estimates are relative to the total cumulative case count, which of course makes sense. A country that has already 100,000 cases is probably having a larger change than a country with only 100 or 1,000 cases. So this is the exposure to adjust for. Then we have the log of the expected incidence rate, and here come into play the parameters that will affect changes in the number of new cases. Hereby we adjusted for country-specific differences with a random effect alpha R, and for weekday effects measured by gamma. But most importantly are the parameters of interest, which are the effects of the non-pharmaceutical interventions. And these were modeled with a time-delayed influence function f of the parameter theta for each measure m. There are various possible influence functions, and in our basic model, we started really simple. So we have two components. One is the time delay, and the other is the type of effect. As a time delay, we chose 7 days. This is based on an estimated incubation period of about 5 days. And then we considered an additional delay, for example, from testing. So we thought that approximately after 7 days, it is reasonable that an MPI can actually show an effect. Before that, it's probably not coming from that MPI, but there is a certain delay until you can see it in the observed case count data. And nevertheless, this chosen delay is, of course, subject to debate, and we ran robustness checks to compare different delays, but we found that the delay, at least small deviations, didn't matter so much for our results. And then regarding the effect, we, in the first case, assumed a simple constant effect. So after 7 days, there's a constant estimated reduction in the number of new cases, which we compute by 1 minus exponential of theta of the measure. Nevertheless, also here we ran a robustness check where we tried, for example, first order spline, and I have to mention this improved our model fit. Nevertheless, we ran the very basic version in our main paper, but we are now trying to estimate the time delay as well as the influence function more precisely. Before moving there, also to say the model was estimated with a Bayesian approach using Markov chain Monte Carlo simulation. Nevertheless, a frequentist approach basically yielded similar results. One advantage for the Bayesian approach was that we could restrict parameters and were more flexible in the choice of priors, and especially for data that is, in my opinion, here quite difficult to model. The priors can be important, especially when we extend our model to country-specific effects. Now about the results, probably few of you have read about it in the media, maybe in the German media or the Swiss media. It got quite some attention to our surprise because we thought, well, it's a medRxiv preprint. Who will care about it? Apparently some people did. And just to make one thing straight sure from the beginning, I have absolutely no doubt that the corona measures helped. And also our study results show that the impact of the non-pharmaceutical interventions is there and it's strong. I think what we're currently seeing in the media with all the talks about removing measures, there's a strong hindsight bias with people feeling that the measures were exaggerated. You can think that they were exaggerated in retrospective, but at the point when decision makers had to decide, I think, in my opinion, it was absolutely right to do these strong measures because there was so much uncertainty. A study related to ours from the Imperial College London, which analyzed the impact of non-pharmaceutical interventions on deaths, for example, found in a very early study that the lockdown had an effect anything between 10 and 90%. I mean, with this high level of uncertainty, it's very difficult for decision makers to make a decision. And if you want to prevent the large amount of deaths and minimize the effect on the burden of healthcare, then I think you should be risk averse and you should take drastic measures. And afterwards, you can evaluate more precisely with good data which measures were more effective compared to others. But at the point in time, I think they did a good job. Having this said, let's come to our results, which are summarized with two main graphs on the right. First of all, the estimated reduction in the number of new cases for each non-pharmaceutical intervention. As said, there's a large amount of uncertainty, even still, right now. So I won't give you a precise ranking of the non-pharmaceutical interventions, because then you didn't really get my point. So what we're trying to say is that some measures seem to have been more effective than the others. And in this case, venue closures, gathering bans, border closures, and work bans were about equally and among the most effective measures in our data, based on our data. And event bans were kind of in the middle, but there you can see what we mean by large uncertainty. The credible interval goes from 8 to 35%, which includes the effect sizes from the more effective measures, as well from the more less effective measures like school closure or lockdown, which in our case were ranked among the least effective measures. So this is to say we can't give a precise ranking of all the MPIs. We can't say this is the best, this is the second best, but we can kind of get a magnitude which were a little bit more effective than the others. And to illustrate what that means regarding cases that were potentially avoided, we used the parameter estimates to plot for each country how many number of new cases were avoided if some non-pharmaceutical intervention would have not been implemented. And this is the graph that is shown on the bottom, and it's only illustrative. We are not doing any kind of causal analysis where we do a counterfactor or something. This is basically just an illustration of the estimated effect. And to me, because it's only illustration, for me was more important to analyze the model fit. And this you can do by comparing the observed number of new cases to the estimated number of new cases. And there for Switzerland, you can see a large gap. And this did not only happen for Switzerland, but also for a few other countries. So we see that our model fit was probably not perfect regarding all countries, and it seems to indicate that that for some countries we may have underestimated the effects of non-pharmaceutical interventions, or that we are missing out on another factor that we're not having in our data set. That is why this is one of the limitations that I was just mentioning right now, and there are lots of other limitations. The limitation is here, first of all, that we make the assumption that all the effects that could reduce the number of new cases are incorporated into our non-pharmaceutical intervention. So we're not considering, for example, behavioral aspects. There are many more limitations, and I probably lack the time to talk about all of them. Maybe you have questions about them, then we can discuss. You can see them all listed in our manuscript and in the supplementary material. But to conclude with the discussion, the important aspect, the important message that I wanted to convey is that what you saw in the media might have appeared much more precise and conclusive than what is actually happening. There's a lot of uncertainty in the intervals, and we are focusing on reporting the intervals rather than the mean. There are many limitations that we're trying to alleviate, and there is much more work to do than we have so far done. And we are working on this. For example, the focus right now is on measuring country-specific effects, because it's very likely that there are country-specific differences. So with all that, please be patient. We are trying to do our best to improve our model. And thank you very much for your time, and I'm eager to hear your questions.
Yeah, thanks a lot, Nico, for the great presentation. We already have 2 questions in the chat, and we also have 1 question from the sign-up form. So I would say we just jump in with the sign-up form first, then afterwards to the questions, and please indicate in the chat if you would like to ask the question in person, or if I should just read it so that I can unmute you in that case. So the first one from the sign-up form would be, how much do you trust your data?
Yeah, this is a good question. So I was involved in the data collection process. So in my opinion, we were of course doing a good job, but as I said, there were a lot of debates about certain measures in some countries. It was not clear if it was actually implemented. Then you had these regional differences. So, for example, US was a good example with work bans, where Trump only recommended it, but some people said, well, it's actually like an actual ban. But to summarize, I trust our data as it is, but I acknowledge that it's not perfect and that there are many different possible data sets and that the results could be different for other data sets. What I have trust in is that based on our data, we can distinguish more and less effective measures, but the data is not good enough to really give a precise ranking. And certainly there are lots of other studies needed with other data sets to replicate our results or to conflict with our results. And with all these studies, we probably finally have a better answer.
Thanks a lot. Okay, Yannick says his question is already resolved, so well done. Then we can go to the next one, which would be, in this case, Kai. Kai has no working mic, so I'm just going to read the question real quick. The question is, I guess some NPIs were put in parallel in place. How difficult is it to relate back results to a specific NPI then? How reliable, constant are the findings when you change parameters in realistic ranges, especially the ones with known uncertainties and developing variability, such as incubation time? And then he lists 3, 4, 14, even 28 days in the beginning.
Mm-hmm. So that issue with some measures being implemented parallel in time, that was also an issue for us, and we thought that it might be difficult to identify the effect of some parameters. So far, it seems that the model is able to distinguish the different effects. The problem will be more difficult on the country, so because I probably missed that. So far, we only analyzed a fixed effect of the measures, so no country-specific effect. And for the fixed effect, I think on aggregation you can distinguish them, but when you go on the country level, within the country where two measures were implemented at the very same time, of course there can't be a country-specific effect that distinguishes these two measures. First analysis I ran so far, it does quite well in the case that it puts the so far I can say that I think it will work, that the model does not some weird stuff, for example, giving a different effect to two measures within a country. But yeah, I will report on this in more detail later, as we have a proper model fit. And but nevertheless, on aggregated level, I feel that we can distinguish the estimated effect. Then how reliable and constant are the findings when you change parameters? We have ran several robustness checks, and there is of course some changes, especially for example for work bans that was affected in a lot of robustness checks, which is reasonable because that measure was only implemented by 6 countries, and you can't tell much about the effect if for all those countries that did not implement this measure at all. So there are changes, but nevertheless, for the different robustness checks, for example, varying the time delay, varying the effect of the influence function, then, for example, do not bound the theta parameter to be positive, to be only non-negative. They so far turn out to be, in my case, realistic in the sense that it changes a little bit, but still the comparison of the least and most effective measures stay the same. And the incubation period is what we were addressing with the robustness check in the time delay. And that is, for example, one of the extensions right now that we are trying to estimate the kind of the best time delay, and as well as the type of effect, so the whole influence function. Give a parameter to that as well, and trying to estimate this one.
Perfect, thanks. There's also a second question from Kai from before. How did you take into account the unbehavior of people not adhering to the rules?
Yeah, well, it's difficult to take this into account. I think this will be captured by the country-specific differences. I could imagine, for example, for Germany, where we have seen the same as for Switzerland, that the the observed drop is much larger than the estimated one, that here the effects of MPIs will be stronger, probably because of greater adherence of the people to the implemented measures. So I hope we can account for this with country-specific random effects. But nevertheless, if you would have good data to measure this behavioral aspect, this could also be incorporated in an extension of the model.
The next question is from Raphael. Have you considered contact tracing as a countermeasure to prevent a second wave?
No, we did not do that, unfortunately. That's something I think is very helpful and also considered among scientists a very effective measure. And we've seen other data sets being collected that have this listed as an MPI. So certainly this could be something that we should include in our data set, and I think it will have an effect. But yeah, we haven't considered it so far.
Thanks. Another question from another Raphael. Did you pick up interactions? So to say, a venue ban is only effective when there was a lockdown happening before?
Yeah, that's something we're also thinking about. The problem is that it's quite difficult because with 7 pharmaceutical interventions, you quite have a lot of interactions, and you can imagine how many parameters you would have to estimate for each interaction term. There are probably other ways we're exploring this. Nevertheless, so far the posterior draws between the parameters for the non-pharmaceutical interventions, they show some slight negative correlation as expected, but it's not too heavily, and it's also with the country-specific effects taken into account, it's being alleviated. So maybe the interactions won't have such a strong interference with our current results, but nevertheless, we want to explore that in the future as well.
Then we have a next question from Matthias. Did you consider the effect of variable testing capabilities across different countries, as it also might be time depending?
Yeah, testing is a big issue. I mean, if testing stayed the same right from the beginning, or if testing processes and procedures were staying the same from the beginning, did not change over time, we believe this should be captured by the alpha R, by the random effects country-specific differences. But of course, if testing changed over time within a country, this cannot be captured by alpha because it has no time component.
Thanks. And then we have one more question. How and by who were the priors chosen? You mentioned that the priors played an influence or something similar. Does that mean that they were chosen to be intentionally informative?
They were chosen intentionally to be weakly informative based on prior recommendations from Andrew Gellman, one of the famous Bayesian analyst guys who I'm following. But yeah, of course, you can always debate the prior. I think we made this choice to make our results slightly more robust, and in a perfect setting, you would need to check your priors as well, of course, or run a prior predictive check to see if with these priors and simulated data, you would get the results that you expect. That is something we also still need to do. But so far on this basic model, we chose, I think, reasonable weakly informative priors to increase the robustness based on the observation that this data is quite difficult to model and noisy in some circumstances.
Perfect. Thanks a lot. And with this, I guess we can also go on to the second talk with Nina. If there are any questions left for Nico, you can still ask them in the chat and we can go over them afterwards, or in the worst case, just forward them to him afterwards if you have questions after the talk. So with this, I would ask you to stop sharing the screen so I can take over, and then we would go over to Nina.
One final point. You can always drop me an email. I'm very happy for your thoughts about the model, as well as if you find any errors in the data, please contact me. We are eager to improve that. I don't exclude at all the possibility that there are mistakes, and I'm happy to correct them. Thanks.
Thanks a lot again. So for the second talk, a very warm welcome to Nina Wiedemann for the topic of automatic detection of COVID-19 from a new lung ultrasound imaging dataset. Nina is doing her master in data science here at ETH, and she's currently writing her thesis on mathematical optimization. And if you're ready, Nina, I will hand over the screen to you, and I'm looking forward to a great presentation.
Thanks. Share my screen. All right, can you see it now, the slides?
Yes, I can see them. Yes, I can see them.
Okay, great. Yeah, thanks for the introduction, and thanks a lot that I can present here. Yeah, I'll talk about detecting COVID from lung ultrasound. And the high-level motivation for that is probably clear to all of you. We've had an exponential growth of cases. We've had different measures implemented, what we just heard about. And now the question is how to get back to normal. And an essential tool for that is testing and early diagnosis. If you can test people early in time, then you can quarantine them and before they infect other people. So that's quite obvious that this is crucial for preventing the spread. Now, what tests are there actually? There's PCR and LAMP. Those are detecting viral RNA, and that's the most direct methods we have. But actually, what many people don't know is that PCR is not as reliable or differently reliable, and this has been shown to have up to 30% false negatives. Then there's antibody tests, and antibody tests are obviously only useful to detect if you have had the disease, and therefore not useful for early diagnosis. And there's medical imaging, actually, which is also not that popular yet. Now I want to get you involved, actually. Does anyone know which kind of medical imaging techniques are already used for diagnosing COVID? You can write in the chat or tell me. Would be curious if someone knows about that.
So we have MRI, fMRI, CT, echoes.
Okay. Yeah, actually, okay. Yeah, actually, X-ray was just set in the chat. That's kind of the first line examination. So this is already used as a first assessment to see if there's any symptoms in the lung, and then PCR is done. But in studies, it was shown to be less sensitive, and therefore it's probably not sufficient as a real diagnosis tool. And then what was also in the chat is CT. That's actually the gold standard, and that's sometimes even preferred over PCR. Although it has several disadvantages. It's quite expensive. Those are these big devices, like big machines, which are really hard to sterilize, and they're highly irradiating, which of course increases the risk for cancer. So what about ultrasound? This is like a summary slide of ultrasound. The main takeaway is that there are certain patterns that can be observed and are specific for lung diseases. For example, those B lines that you can see in the image here. And ultrasound has many advantages. It's quite cheap, only like $140 compared to $370 for X-ray and $500 to $3,000 for CT. It's easy to use. It's really fast. You can do 4 to 5 examinations per hour. It's portable, so you can take it to the patient, and therefore it's really easy to disinfect it. And it's safe because it's non-irradiating. And the main point is it's highly available. So even in developing countries where there's no CT and maybe PCR is not as reliable, ultrasound is available there. So this would be a scalable method. And in the context of COVID, it has actually been shown that certain patterns which can be observed on CT can be kind of directly mapped to patterns that can be observed on ultrasound. So for example, there are those ground glass shadows that you can see on CT, and those correspond to B lines that are visible on ultrasound. And because of this, actually several medical publications have strongly advocated for putting more focus on ultrasound and to explore this as a diagnosis tool. Nevertheless, there are more than 30 publications actually on machine learning approaches for detecting COVID on CT or X-ray, but there is nothing on ultrasound. And our goal was therefore, when we started this project, to fill this gap and to explore if ultrasound could be an option and if automatic detection would be possible. Because if it would for ultrasound, it would be even more valuable because those patterns are not easy to recognize. So I can tell from my own experience, I've worked with this data now a bit, and I honestly don't see anything. Like, I mean, I see those B lines maybe, but really, I have no clue like where we actually are in in the lung. So this would be really valuable as an assessment tool for doctors, or like an assistance system. The output of our work is a preprint, which is now the first publication on ultrasound for COVID. And I will go more in detail now what we actually did. So first of all, we collected a data set, because this is maybe a main reason why people from the machine learning community have looked into CT and X-ray in contrast to ultrasound, because there's no proper data set available, or at least not to the best of our knowledge. We collected data from various online sources, and in the end had 64 video recordings of COVID. So that's the one on the left here. Maybe that's a B line, I'm not sure. Of pneumonia, bacterial pneumonia, where you can see those consolidations here, and of normal lungs, where you can see A lines. Those are these horizontal lines. And yeah, so now, of course, when you find this data online, it's not clean at all and useful for a machine learning model, because it has lots of artifacts, and you can see even those pointers moving around during the video. So first we put lots of work in pre-processing, like cropping, removing those artifacts, selecting certain frames. But in the end, this led to a data set of 1,100 images, which we published on GitHub and make it open access. So the idea is, and that's really important to us, that we actually want to point people to this idea that ultrasound might be informative, and we want to provide a data set that people can get started on. And we hope that people also contribute to this data set, because of course, this is by no means exhaustive, and we think there's many sources out there, such as publications in which there are pictures of lung ultrasound. And actually, we like most data from healthy patients, because it's just hard to find data. So if any of you, of course, is motivated to help there, this would be a great contribution, I think. Now I'm also curious about your opinions. You can also, again, write in the chat or tell me. I'm curious about your unbiased opinions. So what kind of model would you use for classifying these videos or images, which is still not a big data set, and so on? So do you have ideas what you would use? CNNs? That's OLS. UNet, interesting. Yeah, I've heard about that actually just now, that it could be used for segmentation. Okay. Kernel SVM. Okay, cool. Okay, thanks for your input. We can discuss that later, or go more into detail, and I will actually consider that for improving our model. So what we did is just quite a simple. It was more thought of as a proof of concept model, whether this data is actually informative. So we did use a CNN, as people suggested, and we used the pre-trained VGG network such that it basically extracts the basic information, or like low-level information, low frequency information. And so we take those layers and fix the weights, except for the last one, which we train, and add a dense layer and batch normalization. Also for like to prevent overfitting, because it's still not much data, we apply dropout, and we use data augmentation techniques such as rotation and shifts and flips. Yeah, so but as I said, this is really simple, and this needs to be improved definitely, or needs to be explored what other models could be taken. So these are our results. We actually achieve 89% accuracy on classifying between COVID, pneumonia, and healthy. So this was what we first did, was just a classification task. It would be interesting to look into segmentation at some point. But for classification, you can say that you can see here that pneumonia is quite distinctive, so it can be distinguished quite well here with good values for precision and sensitivity. Also, what is a really promising result is that for COVID, we get 96% sensitivity. So this is the important indicator, because in the current situation, we don't want many false negatives. It's fine if some people think they have COVID, but they don't have it, but the other way around is obviously worse. But what must be improved definitely is the false positive rate, though. So you can see here that still many healthy patients are being predicted to have COVID. So we will work on that in the future, and are already trying to improve our model to get better results there. And we also compared our model to some others. For example, one that was proposed for classifying X-rays, called COVID-Net. And we took the code from the authors and applied it on our data, but unfortunately it was not able to deal with the unbalanced classes on our data. So it only predicted COVID and pneumonia, or pretty much only. And therefore it has inferior F1 scores than our model. Another thing that we looked into, which we thought would be really valuable for doctors, for example, if you would really build such an application, is if there was interpretability. So we implemented a method for class activation maps. It's a gradient-based method for feature attribution. And you can see here that it basically, from the last convolutional layer, it recognizes where, or it kind of tries to understand where, like which part of the input was most decisive. And you can see an example here of COVID, like this is a COVID case, and it seems to pick up something here. But here for pneumonia, you can see quite nicely that here those consolidations and those are actually picked up quite well. As I just said, it would of course be great to have some application in the end, if this really proves useful. And we did build a little demonstration service, like a web service as a demonstration. So one of our team is a web developer, and he deployed the model and built a service where you can upload your own ultrasound images and get a prediction. And also you can upload images here to contribute to the data set. So apart from GitHub, this is also an option. So what's next? As I said, we want to collect more data. Actually, we already, so one of the team, she had access to an ultrasound device. So we actually now recorded healthy patient data on our own. But as I said, there's a lot more things that could be done there, and there's definitely help wanted on that. You can also scan the QR code to our GitHub. This is the main landing page, and the code and data is accessible there. Secondly, we want to improve the model. And this is, of course, might also be relevant to some of you, because many of you have experience with machine learning. And so, yeah, feel free to fork the GitHub, and it's probably really easy to improve our model. So there could be many things tried. And I'm also curious about your ideas in the discussion, if you have other ideas what to do. So we thought about video classification, for example, or segmentation. But of course, for this, it's hard with the data we have. But yeah, I'm happy to hear any ideas on that. The long-term goal of us would be to conduct a clinical study in the end, because that's the only way that you can really validate the approach, whether it's useful for doctors, and to compare to CT and X-ray. So in the optimal case, we would be part of a clinical study where CT and X-ray and ultrasound are used on patients, and the automatic detection models are compared in this controlled setting. But of course, this is a long-term approach. But here also, if you know anyone who might be interested in conducting such a study and would be interested in also trying these automatic detection approaches, it would be great to get in touch. So thanks for listening. Here's some further resources if you're interested. We also have a YouTube video and a blog post. And thanks a lot to the team. Without them, this project wouldn't exist, obviously. Thanks for people for helping in the data processing and acquiring data, and thanks to the hackathons for their support of our project. I'm happy to hear questions.
Yeah, thanks a lot for the great presentation. Could you just mute yourself while I talk? Otherwise, we can have a feedback. That would be perfect. Thanks. Before we start with the questions, I'm just going to post one link where you can leave feedback for both speakers and also for us in general, so that we can make this event even better in the future and constantly improve. So if you also have questions that you can think of afterwards, you can also put them in there and we will forward them to the speakers as well. So Nina, we can go into the first question, which Kai was asking during the presentation, which is, I thought PCR are in particular very reliable in the first week, and for later tests, PCR is not applicable anymore. Hence, is the statement made before really valid?
Okay, thanks. The statement was, of course, is maybe too short to really put that into detail. As I said, PCRs, the reliability is very different. It has just been shown that in certain cases it is not necessarily reliable. Also, during the first week, and later it's not reliable anymore, and that's also an important point, because actually ultrasound and OCT can also be used for monitoring. So it's not only a diagnosis tool, but it could also be used for monitoring the disease and the progress of the disease. So that's actually an advantage for those medical imaging methods. But yeah, I mean, I don't know all the literature about PCR, and I'm sure in general it's a really good method. I just think that it's always useful to explore different testing ideas, because maybe in some places PCR is just not available, the capacities are too low, and so on.
Thanks. The next question is from Teresa. Did you also consider other performance measures besides, if people jump, text is jumping if people type, so I'm just going to look for this question again. Did you also consider other performance measures besides accuracy, for example, AUC or F1 measures, and how balanced is your data set?
Okay, thanks. You can still see my slides, right? Because
yes.
we did compute AUC scores for actually then for the binary task, always COVID or not, or pneumonia or not. You can see the curves here. These are the IU's ROC curves, and the scores are here in this legend. You can see that for pneumonia, it's definitely the best. And we also plotted this point of highest accuracy, which is higher for COVID, which we think is actually good in our setting, because this means that if you put the threshold, then we rather have false positives than false negatives. Regarding the second question about how balanced our data is, it's not that balanced, but for our model, we also computed balanced accuracy. I think it was around 83%. So as I showed in the confusion matrices, the main problem is that too many healthy patients are classified as COVID, and this might also be, one reason might be that it's unbalanced and there is not much regular data. So I think I showed in the data set. So we have 39 videos for COVID, 14 for pneumonia, and 11 for healthy patients. And we sample with 3 hertz from each video and a maximum of 30 frames, such that no video is highly overrepresented. So that's what I can say to that.
Thanks a lot. The next question is from Matthias. Where did you get your ground truth? You were talking about the same methods lead to false positive.
I'm not sure if I understand the second question.
Yeah, you were talking about that same methods lead to false positives. So if Matthias would like to elaborate You can just type it in the chat. Or I can also unmute you if you prefer.
Okay, so.
Okay, Matthias would like to be unmuted, so I'm just gonna look for him in the chat real quick.
Oh,
Matthias,
okay,
you are live.
Yeah. Hi, Nina. Yeah, thanks for the talk. I have the question. At the beginning, you were mentioning that some methods lead to false positives, and therefore you might have label noise in your data. So how did you make sure that your ground truth was true for these videos or images?
Okay, so I'm not sure what I said. Maybe I said, maybe I formulated something in a wrong way. What I mean, the ground truth we got is basically that the data that we found online was usually labeled, right? So we found videos online where someone showed the video. It was maybe a tutorial where someone showed the video and said, yeah, here you can see a healthy lung, you can see those patterns. And this is how we get our labels for our data. And maybe what I said is the method we use or the model we use has quite a lot of false positives, which means that our healthy patient, that the healthy patients are predicted as COVID. But in the ground truth data, the ground truth data should be okay. We actually let a medical doctor check it. So we have a medical doctor in the team, and he checked the data and put comments. So it should be fine mostly.
Okay.
So if this fully answered your question, I'm going to go on to the next one from Kai. It is not yet fully clear how much of the impacted lungs were recovered back to normal. Did you take into account images from various points in time of the same candidates?
That's a really interesting question. Yeah, so it's referring to the state of the disease, right? Actually, that's that's a problem we considered because we have, for example, data where doctors say, okay, this is day 1 of COVID, and they know that this patient has COVID, but they say that you can't see anything on the lung ultrasound. So we were struggling with this data because it's hard to tell whether this is now a normal lung or this should be COVID, because maybe the model can detect something on it. I think we did label it COVID and try to use it. But I mean, the thing is really our data is just assembled from those sources, and often this information is not even available. So this was just 1 or 2 videos where we know which date of the, how much the disease was progressed, and therefore we couldn't really take this into account so far. I mean, if we had collected data for which we know this information, it would be really interesting to take into account.
Thanks a lot. And then there is one more from Matthias, which is pretty much going into how far did you incorporate time-dependent variables, such as people breathing in and breathing out?
Yeah, I mean, it's a general problem of ultrasound that the examination is performed differently, and so there's no proper, or not many proper procedures how you move the ultrasound device over the body, basically. So it's in general, it looks really different, and it's of course difficult. It's therefore really difficult to say from images, because doctors can often see something by moving the device over the body because they know where they are, and this makes the task harder. We therefore wanted to look into video classification. Actually, one team member is already working on that, because then this time-dependent information can be used. But so far, I mean, yeah, she tried with splitting the video into segments, of course, but still it's not much data for such high-dimensional data as videos. So, but I mean, any ideas are welcome. What you could do with that?